Hi everybody, it's Professor Miller. This lecture is going to cover the respiratory assessment. It's split up into different sections. This first one's going to take a look at the introduction to physiologic structures and anatomical landmarks. So this will give you that general idea as to, how to approach the exam and what to kind of look at. And then the second part focuses on the subjective and objective data. So that's like your history taking and your examination. So right now let's take a look at the physiologic structures and landmarks. So when we look at the thoracic cage or, the thorax of an individual or a patient, you're looking at the anterior portion, which is the front, and the posterior, which is the back. Some certain landmarks, like your C7 vertebral prominence, like right here, it's actually at that neck, kind of the bone that's at the base of your neck, where it kind of meets your shoulders, essentially. That's kind of a good landmark for looking at where the thorax begins, because a lot of times the apex of the lungs extends above this. Same thing when you're looking at the anterior view. We look at like the sternum, the suprasternal notch, and then your clavicles. When you're looking from the front, the apex of the lungs actually extends above your first rib, and it's actually like 3 to 4 centimeters above the inner third of your clavicles. So the inner third of your clavicles will be right here. And it actually extends a little bit above that. So that's kind of an important concept to remember, that your lungs actually go a little bit above your clavicle. Another area that we look at too is like the costal angle. Your costal angle is essentially looking at the expansion of the rib cage. Because when we talk about, disease states like COPD, a lot of times patients can have hyperinflation of the lungs or the chest cavity, and they actually will start developing what we call a barrel chest, where the diameter of the lungs is actually the diameter, like the AP diameter of it actually becomes expanded over time because they have hyperinflation of the lungs. So a lot of times we'll look at, we don't specifically look at it, but it's just one of those observation things that you kind of look at is the costal angle. And it's typically 90 degrees or less. And usually if it's increased or above 90 degrees, then we're more concerned with like hyperinflation or overinflation of the lung cavity. Sometimes you'll see this with emphysema, if the patient has like a barrel chest, and we'll kind of talk about that a little bit later too. When you're looking in general at an exam and you're doing percussion, you're always going to be doing it in between the intercostal spaces, because obviously if you're doing it over bone versus lung, you're going to get different sounds. So that's just another thing to kind of think about as well. Another landmark that we kind of look at too is like your angle of Louis, and then which is like that angle where the manubrium of your sternum kind of goes down. If you were to feel on your own chest, you can kind of feel where it starts to go down. And this is another important landmark too, because we look at, this is where like the bifurcation of the bronchial tree kind of comes from. So it'll kind of go down and then like bifurcate out over here too. Just another area to kind of look at. So the sternal angle is where it bifurcates essentially. So as I said, C7 on the back of your neck, the vertebral prominence is basically where we mark that landmark of the apex of the lung tissue on the posterior side. When you're looking from the bottom part, or you're looking for how far down the lungs go, or the base of the lungs, it's typically at T10. However, when you have inspiration, it drops down to T12. So, you may want to go back to that image and look at that real quick, but that'll give you the base of your lungs as to how far down they approximately go. Some key areas to kind of know too, lobes of the lung, obviously as you go through this, you're going to figure this out, but lungs are paired. We have two of them, or two sides, I should say, not two of them, but they're not precisely symmetrical. So this is kind of an important concept to understand, because when you're listening to lungs, the borders of them are going to be a little bit different between right and left. The right side is actually shorter than the left because you have the liver there. So the liver is actually kind of shifting the right side up a little bit, so it's a little bit shorter on the right side because of the liver. The left side is narrower because your heart. So your heart kind of pushes it to the left a little bit, so it makes the left lung a little bit narrower. And you can kind of see this on the next image, next slide when I go through it. The right side has 3 lobes, the left only has 2. So that's an important thing to remember. There's 3 lobes because, a lot of times, like if you were to look at a chest x-ray or a reading from a radiologist, it'll say, right middle lobe has, infiltrates, or they'll, specify which lobe it's at. And that's important to know too, because if you're doing your exam, you want to correlate that with your diagnostic testing and look at, okay, do they have, pneumonia on the right side? Because it could only be, sometimes it's on one side versus the other. So that obviously is important to understand which lobe it could be in, The left side does not have a middle lobe. The right has three, left has two. When you're looking at the anterior and posterior side, too, this is another important thing, just for kind of same type of reasoning of knowing where you're going to listen if there's a problem. The anterior chest has mainly your upper and middle lobe with very little lower lobe. So you're both right and left side, essentially. But when you're looking or listening to the left or the posterior side, this is almost all lower lobe. And if you look at an image, I'll show you on the next page, it kind of makes more sense when you put the picture together with it. So anteriorly, if you're listening to, let's say, for instance, you are, the patient has upper lobe pneumonia, you're going to really want to listen up front because the front is where the upper lobe is mainly located versus when you're listening to the posterior. However, if like the patient has lower lobe pneumonia, which is actually fairly common, you're going to want to listen in the back more because of that. Just some thoughts, to put together when you're doing an exam. As I mentioned before, right side has your three sides, your superior, your upper lobe, middle lobe, inferior lobe. Left side, superior lobe, inferior lobe. In this picture, it's a little blurry, sorry, but it kind of gives you a good idea as, remember I mentioned in the back, you're mainly lower lobe. See how big the portion is compared to your front. You can barely listen to the lower lobe up front. And vice versa, the left upper lobe, right upper lobe, and middle lobe, you listen to up front, but you really can't get a great listen in the back. And even on this image, it's hard to see, but you can see that the right is up a little bit more because of the liver, and the left is actually a little bit more narrow because of your heart. So these are just some things to kind of think about when you're listening to lungs. Now, real quick, I wanted to go through this, the pleural space, because you have that lining on the outside of your lungs. And the pleural space, it actually is a potential area for issues to kind of occur. It is filled with a little bit of fluid. This is lubricating fluid, so it's normal to have some fluid in there. But however, sometimes we get like pleurisy, where they have inflammation of the lining of the pleural space, or that lining in there. And the pleural space is actually an area too where we get pleural effusion, so they have fluid buildup. The pleural space is also the area where that is affected by pneumothorax. So just so you have a greater understanding of what the pleural space is, essentially, I just have some images down here of, you don't need to know like close, open, tension. I'm just trying to give you an example. So there's that negative pressure essentially in there, and that's what's holding your lungs up against the chest wall. So when there's any trauma to the chest wall or opening into that pleural space, it disrupts this pressure in there. And we'll talk about this as we go into negatives, but I'm just trying to explain to you what the pleural space is and why it's so critical, or can be detrimental if there's issues that occur. So that negative pressure gets, the balance gets upset there, and this is where you can have issues like there's a lot of issues that can occur within the pleural space. If you think of the pleural space, it's similar to like a 2-glass slide. If you were to think of a slide that you look under a microscope, they're difficult to separate, but they can slide back and forth. So this is what gives it that lubrication, and you want lubrication because when you're breathing in and out, this is what that creates that movement and smooth movement, essentially. The trachea and bronchial tree, wanted to cover this real quick too, because obviously it's part of your airway. A few things that you really need to understand here, because it'll help you understand some of the abnormals, is the alveoli. We kind of describe them as clustered like grapes. I'm sure you had a lot of this in your anatomy and physiology class, but just remember that this is actually where the gas exchange occurs. So I have another image on the next slide, which we'll look at, but you have your pulmonary artery and your pulmonary vein. So when it's coming from your heart to your lungs, it's coming from the pulmonary artery. Remember, your pulmonary artery is unoxygenated blood, and this is the only place that it's opposite. And you probably remember that from patho or A&P. And the pulmonary vein is the only vein in the body that has oxygenated blood, because it's going back after it oxygenates through the alveoli. It goes back up, to the heart to go out to the body. But the important thing to kind of know here is that the alveoli, this is where the oxygen and CO2 exchange occurs. So if there's issues here, which commonly occurs with, pneumonia or COPD, it's affecting oxygenation and tissue perfusion in the end. So just kind of think of the alveoli like a cluster of grapes. It's a huge, when you look at the surface area of it, they compare it to as a tennis court. In your book, I compare it that way, but this is the area it's at that very microscopic level that we're having all these changes. I mean, it's not to say that you don't have changes up in the upper airways, but a lot of times, a lot of these disease states affect these smaller airways. So, like I said, pulmonary arteries, unoxygenated blood, it goes in through, the capillaries in your alveoli, and this is where the gas exchange occurs. So you're getting rid of CO2 and then oxygenating and then sending it back up to the heart and then out to the body. Just a few another anatomic locations. Like I said, you have that costovertebral angle, your pleural space, and then looking at a cross section. So if you were to slice this way and look down upon it, so if you're looking down upon a cross section, this would be your spine back here. These are the lungs. Remember how I said a lot of times too, like if the patient has a barrel chest, this diameter, when we talk about AP diameter, we're talking about anterior, which is the front, to posterior. And I'll cover this in a minute, but with COPD or emphysema, sometimes these patients have an increased AP diameter. So this will become more rounded out instead of oblong. It normally should be oblong, kind of rectangular oblong shape versus round. Mechanics of respiration, the major function of the respiratory system is obviously oxygenation, supplying oxygen to the body for energy production. So your tissues need oxygen in order for ATP to occur, essentially. And it's also obviously critical to remove carbon dioxide. So this is the waste product that we're removing from the body. Our body maintains homeostasis, or basically what we call acid-base balance of arterial blood. And a lot of this is done through chemoreceptors, which I'll go through in a moment. But it's an important concept to understand because there's a difference between people with chronic lung disease. A lot of their drive is off of oxygen, where in the average person with normal healthy lungs or pulmonary function, our respiratory drive and homeostasis is maintained on CO2 levels. Theirs isn't. So it's a little bit different when we talk about abnormals. It's something to think about, which we'll talk about later. But like I mentioned, our tissues are bathed by blood that's normally has a narrow acceptable range of pH. So this pH it has to stay in with this level, or you end up with some imbalance. This is an example of what we kind of look at with an ABG, an arterial blood gas. You usually don't run into this on every floor, but if you work on like a floor that has a lot of pulmonary patients, if you work in an ICU, you'll be using this stuff all the time. But as I said, like our pH has this small therapeutic level, and basically our body compensates to regulate this pH. And our lungs and our chemoreceptors are what is kind of maintaining this. We're adjusting those carbon dioxide levels through respiration. So like I said, in the average person with no underlying pulmonary disease, CO2 is what is kind of triggering this. Hypoventilation, it's exactly what it means. Remember, hypo means less than or under or slow. So hypoventilation would be slow, shallow breathing. So it's important to note that even though your patient could have normal respirations, they could have a respiration of 12, you have to look at the rhythm of like the depth of the respirations, because they could be breathing at 12, which is normal, but it could be very shallow. And you might see this like in a patient that had, postoperatively that had anesthesia, a patient that had, significant amount of narcotics. They may have hypoventilation, so they may have a normal respiratory rate, but you have to look at their, the inspiration and expiration that that's going on with the patient. Hyperventilation, usually with this, you're going to have rapid, deep breathing. So this is hyper means, up or rapid or increase. And when you're having hyperventilation, this is going to cause CO2 to be blown off, essentially. So they're complete opposites. Hypoventilation, CO2 is going to build up. Hyperventilation is going to blow off. You don't have to know all this. I just put that up there for an example of acidosis that can occur. So we have respiratory and metabolic acidosis, but usually with this, we end up with respiratory issues. So patients that are on ventilators, a lot of times we'll tweak their settings because their pH may be a little off, or their CO2 might be up a little bit. So we'll change their vent settings based on these factors. In terms of control of respirations, like I said, it's that major feedback loop, just like we talked about before with your carotids and a lot of your pulse and blood pressure and stuff like that. A lot of it's through that feedback loop. But like I said, it's in the average person, it's based off of CO2 levels and O2 levels, but mainly CO2. And this is what's going to trigger changes so that you keep that the pH level normal. So an increase in CO2, which we call hypercapnia. So hypercapnia means increase in CO2 or elevated CO2 levels. And then decreased O2 is going to be hypoxemia. So there's a difference between hypoxia and hypoxemia. Remember, hypoxemia, anytime you see this, is going to mean in the blood. So hypoxemia, if their O2 levels are low, this is going to also increase the respirations, but it's less effective than hypercapnia. So like I said, a lot of the respiratory drive is based off CO2 levels, not O2 levels, and that's in the normal patient without underlying lung disease. It's the opposite with COPD patients. So we'll talk about that later, but it's a kind of important concept to understand. Changing in chest size, obviously when you inspire or you expire, it's going to change the size of your chest. Respiration is actually this is another concept to kind of understand too. Respiration is the physical act of breathing. It's different than ventilation because we kind of look at two separate areas. And perfusion is another area that we kind of think about as well. So air is going into the lungs, your chest size is going to increase and open up basically during inspiration. And then when you're expelling from the lungs, you're going to have chest recoiling. And that's what we call expiration. In patients that have COPD, a lot of times they have issues even with chest recoiling, so they'll have issues blowing that CO2 off sometimes too. The mechanical expansion and contraction of the chest cavities is what's altering that your thoracic, they call it container, your thoracic chest essentially in 2 dimensions. So it's going to increase that AP diameter, and then it's going to increase your, going sideways essentially. So the vertical diameter is going to lengthen and shorten by downward and upward movement of the diaphragm. So your diaphragm and your intercostal muscles are what supports respirations essentially, because these are the muscles that are going to be opening and kind of letting that recoil occur. So as your AP diameter, like I said, from the front to the back, like your spine to your front, is what's going to be done by your basically elevation or depression of your ribs or intercostal spaces. So all those muscles that are in between your ribs are what increases that AP diameter. Another important concept to kind of understand or put it together is because a lot of times you'll see, especially in the child, you'll see it more frequently in the pediatric patient, but you'll see use of intercostal muscles. Like if you were to look at a baby or a toddler and they're breathing really heavy, a lot of times you'll see those intercostal muscles working because they're real thin, and you can actually see that work being done there with their muscles. A lot of times you'll notice that when they're in respiratory distress. It's just a little bit different than the adult, because the adult, sometimes you see it up more by the neck and above the clavicles, where in the kid, you'll see it above there, but the kid, you'll see it a lot in the diaphragm, like the abdomen, or kind of by the ribs too. This is just another image, like I mentioned. This is for regulation of respiratory control. So your chemoreceptors and your brainstem obviously are areas that are going to affect respiration. So if you think about any abnormal cases, such as a patient that had a traumatic brain injury or a stroke and it affects their brainstem, obviously that's why we have issues with respiration. And sometimes they can have, hypoxemia from it because they're not breathing properly. They may have a respiratory rate of 6. So obviously your brain, if there's any injury to the brain, it can affect respiration essentially. Your muscles breathing, so obviously that's going to kick in, and your diaphragm and your intercostal muscles and all that kind of kick in, and that's what's supporting your breathing. Your ventilation rate at the alveoli. This is another area to kind of understand too, and we'll kind of go through this when we look at pulse oxes, because you have to know the difference between ventilation and basically tissue perfusion, because there's multiple factors that can cause hypoxemia, not just the lungs. If you think about, perfusion and all that, there's 2 issues that you really have to look at, and we'll kind of look at that as we move into the pulse ox. So this is what's maintaining, obviously, our blood pH, our PaO2, and our PaCO2. And we'll talk about that with the pulse ox a little bit. It'll kind of make more sense as we look at that. Real quickly, developmental competence, just wanted to bring this up because of pregnancy. Obviously, the uterus is going to put pressure up onto the diaphragm, so it's going to push all that up. And that's really why a lot of pregnant women towards the end have difficulty, or some may just complain of a little bit of shortness of breath. It's abnormal to have significant shortness of breath, but a little bit of shortness of breath is not abnormal. So it's increasing that vertical diameter of the thoracic cage, but it's usually is compensated by an increase in the horizontal diameter, so kind of going out horizontally versus upwards. And a lot of times with pregnancy, your hormones have a huge impact on a lot of your tendons and ligaments and muscles. So the estrogen actually lets the chest cage ligaments kind of relax, just like it does in the pelvis. It does the same thing in other areas like your lungs to kind of help compensate for this. And essentially that diaphragm moves more during pregnancy, so you're going to have an increase in tidal volume, which is going to kind of make up for or compensate essentially for that pressure kind of putting up. The growing fetus increases oxygen demand on the mom's body. So obviously anytime a mom that is pregnant and has underlying heart issues or pulmonary issues, you have to really, really watch them. When we're looking at the older adult, a lot of this is due to physiologic changes, or I should say more of their stature changes, like they get that kyphosis where they kind of have that bent forward stooped appearance, and a lot of times that's with osteoporosis. Even like their costal cartilage, it becomes more calcified, and it's not as mobile because it's not as flexible essentially as what it would be in a younger adult. So it becomes more rigid. It's harder to inflate. Even their pulmonary structures or even their airways they become less elastic, I guess that's how I would describe it. And there's even histologic changes. So at the smaller areas, when you even look at the alveoli, they have a decrease in number. They have loss of the septi, which is in between the alveoli. So basically there's less surface area for gas exchange. So they're just more apt to having complications with pulmonary disease or anything, or pneumonia or anything like that because of all these factors. The lung bases are less ventilated because the closing off of the airways, just because of the, like I said, like the expansion of it and all that. So that's why it's so important too. Like after a patient, let's say they're in the hospital for something even not related to their lungs, it's so important to get them up and moving and deep breathing and coughing, because we need to get them using their airways and we don't want it to become worse. So that's why a lot of times you'll hear about coughing, deep breathing, getting your patient up to walk, and a lot of this is just to maintain that pulmonary function in your patient. So like I said, these changes can increase their postoperative pulmonary complications, and it just takes them longer to recover sometimes. And, we always worry about getting like atelectasis or even pneumonia after. And these are the reasons why they end up with these pulmonary complications, because, like I said, they don't have good opening of their chest wall, essentially. And they just have these small changes that can put them at risk. So this will be the conclusion for the first part of the lecture. The next section said I will go on to that subjective data and your objective data, so your history and physical exam. And it's continued on within this PowerPoint slide. Thanks, and let me know if you have any questions.